update. Crossland PLC is doing our audit again. They're also doing Metro government's audit as well. We are in the middle of it. It started officially in October. It is going to be an all virtual audit this time from Crossland, which is new for us, but they're local, and we are well underway there, and we look forward to completing our 8th straight year of a clean audit without any issues. So that's the audit update for 24, Chair.
Thank you very much. Next item, back to you for financial statements, August 2024.
All right. The month of August, we're reporting on busy inpatient hospital month. We had 254 admissions for the month. That's about 15% higher than the budget of 220. We also had 192 observation admissions, which was about 10% higher than the budget of 174. And patient days were similarly 15% higher than the budget. When you look at length of stay at 3.9, which is really great, excellent performance. That's right on the budgeted number. That's 15% better than what our average was last year. But because we ran that number last year, that is our budget for 2025, a much shorter length of stay than previous. Otherwise, our emergency department visits were basically flat with the prior month, but they are about 5% higher than the budget for the month. Emergency admissions of almost 200 were 20 admissions above the month. Our clinic volume this month was strong, 4,800 visits, well above the budget of 3,800 visits. Surgery, both inpatient and outpatient, was down just very slightly from last month, which was really a strong month in those two areas, but we're still above budget on both of those areas for surgery. Where we are low, admittedly, cardiac cath lab volume is very low, less than half of what was budgeted. Back at the end of May, we lost our interventional cardiologist, and so we don't have that service back yet at the hospital. We're working on it, and we do have an interventional radiologist and a vascular surgeon that do some work in the cath lab, but the volume is down pretty remarkably since his departure. Deliveries, again, continuing to be low. Really, for the last 14 or 15 months, our deliveries have been in the mid-20s, and again in the month of August as well. Any questions about that? Go ahead.
A comment. I want to add to that explanation. It wasn't just that the cardiologist was not there, but we were installing a new cardiac cath lab. So even if we had one, we would not have. But that's fully installed at this point.
But do we have some prospects for cardiology?
Oh, yeah. Yeah. We have an interventionist that'll be starting as soon as we get him financially credentialed.
Okay, good.
And of course, we do have the existing 2 providers that are here. So that'll be 3 providers that we'll have in total, and probably rounded out at 4, but that'll be over time.
The 2 that we have are cardiologists, or you're talking about the interventional radiologists?
Oh, no, I'm talking about a cardiologist. We have a cardiologist and a cardiology nurse practitioner.
Okay.
And then we have an interventionalist who has signed with us and will be joining us as soon as we are able to get him financially credentialed.
When you say that that's half of what was budgeted, what is that? Is today we're at half of what's budgeted, and
Yeah, Chrissy, we budget a year at a time. You know, we're required to provide a budget to Metro in usually end of February. So in February, we did not know the interventional cardiologist was leaving, and he departed at the end of May. So we had budgeted with the expectation we would have him. We've got a gap right now until we get the new cardiologist in the house, but we also have construction, as Dr. Webb mentioned, so we will have the new cath lab up within. Okay, it is up. Now we just need the provider. But we don't change the budget in the middle of the year. I mean, technically it's a legal document. We could change the numbers, but we do not.
No, I know we don't change it, but I was asking about, like, right now, what kind of impact has it already had in dollars?
The lack of cardiology revenue, to me, I mean, and
Right.
my controller's back there, it's down significantly. Cardiology revenue is down significantly just because we don't have that interventional cardiologist here to produce sort of the bigger dollars. We have general cardiology, but we don't have interventional right now.
Is that, I mean, I guess I just don't understand what the budgetary item is that we have for that specific area. Is that $1 million? Is that $500,000?
No, it's probably $1 million of gross revenue a month between the professional and the technical for an interventional cardiologist based on what our prior interventional did. So that's not net, that's gross. But still, it does have a significant impact.
Thank you.
Okay, so on to the income statement. You just heard that our inpatient days were about 15% above the budget. Similarly, our inpatient revenues were about 15% above the budget. The outpatient revenue was well below budget for the month. The cath lab is a big chunk of that. We just don't have much volume in there currently, and it was down for repairs even if we had the doc. Then also observation days, even though observation admits are good, we're moving people through the system so quickly that our observation days are down about 80, and that's just like 80 real patient days. And it's okay but it does have an impact on outpatient revenues, not net revenues, but gross. As far as what we harvested from the $26.5 million gross, we achieved the 18.4% net revenue rate, just below 4.9 million, and that was about 300,000 behind the budget that we had for the month. Our total net revenues with our other revenues, we were about 200,000 favorable for the month, 12.9 versus 12.7 million. On the expense lines, salaries are and contract labor, those were about 800,000 negative for the month. And then just physician services is probably the other outlier for us in terms of budget. And those items pushed our expense line $1.1 million higher than what we had originally budgeted for the month. And that produced, so we had a 200,000 favorable on revenue, but a 1.1 million unfavorable on expenses. And we ended up with a loss for the month of almost $1.25 million. The budget was we were supposed to lose about 360 in August, so a negative overall for the month. Any questions?
Bruce, what would you say, is most responsible for the operating margin deficit? Is it cardiology or is it expenses? What?
I mean, I think Dr. Webb and I have these conversations all the time. I think that we've implemented some new things and programs over the last 4 to 6 months. The Bordeaux Clinic, the imaging center. We're trying to bring in another interventional cardiologist. We're building out that old cath lab even as we speak, replacing it, and I think it's ready to go. So we've encountered some things that weren't necessarily known at the time. So we're spending the money and we're not yet harvesting the revenue. That is in the projection going forward. But Bordeaux Clinic is net new. The imaging center there is net new. We've got real bodies there staffing those and physicians seeing patients. It's going to take a little bit of time before they start generating a net new margin for the hospital. They're good investments, and we need that demographic in Bordeaux because that's people my age who are likely to use services. No disrespect to the 40-year-old people in some of our other locations, but it's going to be the 60 to 70-year-old people that are more likely to be referred into the hospital for service. So I think it's a safe bet. We just got to get it fully operational, and I think we'll get there.
I think the cardiology situation is not probably what it might appear to you to be. The general cardiology services that were being provided by those 4 cardiologists is actually being done at the same level by
One.
the 2
One in a NP.
providers that we have. The interventional was a different contract, which was very limited as to their availability. So now that we're implementing a new cath lab, a state-of-the-art cath lab, and bringing on a full-time interventional cardiologist, we'll see where we were losing on that proposition, but this will be a major gain for us.
That's all I had, Christy. I don't. Chair.
I actually had a question you didn't hit, but wanted you to address it if possible, Bruce. The Metro indirect piece we're talking about on page 4 of this report talks about the absorption of security contract costs comparative to the, I guess, the receipt of services and the cost of security of services to the hospital. So I'm just curious about what is the benefit that we're getting in terms of dollars versus the cost that's going out? So what the net effect of this annually?
Okay. I'm going to give you an honest answer, not necessarily a politically correct answer. Dr. Webb will probably wince, but
It's right up my alley.
I'm just, many years ago when we were part of Metro government, okay, the hospital literally was part of Metropolitan government. They provided the sheriff's office deputies here at no cost to the hospital because we're related, right? Similarly, they brought their detainees or arrested folks here to the hospital and we took care of them at no cost. Then we broke away and became an independent hospital authority. Somehow in that conversion process, we still had the responsibility for security at the building, and no longer was it provided for free. They basically said, here, you can use this contract, and it costs us about $1.4 million a year for that. So it's one of those things that just sticks in our craw. And then the other part of it is, and I have Dr. Blackledge here next to me, but we did look at the last 12 months. We continue to provide free medical services to the sheriff office detainees. The average charges for those patients is a little over $12 million a year. So at our cost, that would be about $5 million reimbursement to the hospital. So when we talk about how things have changed, we picked up a $1.4 or $5 million contract that used to be responsibility of Metro, and we don't get paid for that $12 million of service that we provide in the emergency department and throughout the hospital every year. So that's why I said, I know that's sometimes unpopular, but it's one of those legacy issues that still carries forward, even though we're not part of metropolitan government technically anymore. So,
And who, excuse my ignorance, but who would address that if we need to revisit that discussion? Is that the mayor's office? Is that a conversation with the
I
sheriff's
would have
office?
to defer to Dr. Webb on that.
We have someone who is currently addressing that issue. We know that there is funding for those services, but they're obviously going into another system and not making its way to us for actually providing the service. So that is something that our chief operating officer is in dialogue with currently.
Okay, great. I'd love to hear an update on that once you have the opportunity to see that through, because it's a big number every year for us to absorb, and the net difference of the 1.4 versus $12 million. I mean, that's just, it feels like it's a pretty glaring issue to be dragging on without some real updates and in collaboration. So I think that would be helpful for the board to understand that in a depth.
Chair, can I just,
Of
one more
course.
point of clarification. The 1.4 million is an expense to us. It used to be free, so we're bearing that 1.4 and we're not getting paid that 5.
So it's
So I would
really
add those
more.
two together, not offset them.
Gotcha. So 13.4 is really the issue.
It's really 5 would be, if it was an insured population, we'd probably get about 5 million for the 12.
Got it.
Okay?
Understood. Thank you
All
for
right.
the clarification.
Sure.
Thank you for the explanation. Okay, next item on the list is a revenue cycle. Dr. Blackledge?
Sure, thank you. Good afternoon. So first up, from a team standpoint, I just want to commend the team here, as Bruce has spoken about the revenue, but this is what happens once we actually receive the revenue. So the team has been working together, and I could commend them for their certain achievements. I have an introduction. We have patient access leader, Melissa Tabor, if you see. Hello. Hey. Just want to make sure I always share a face with a name. She's new. We are onboarding her. This is day 2, I believe. And so we have Faith Reed, who's present in the audience, and Faith always takes care of our utilization management need. And then Mark Chase in the back, he takes care of making sure the dollars make it to the bank. Very important. As it relates to our cash, and we compare it to our net revenue, and then Bruce has spoken a little bit about that, but I want to make sure I point out a trend that lets me know all indicators are heading in the right direction. So if you look at March, we had a low point of March, but if you look over the period of the 7-month trend, you can see that is steadily increasing over time. I do want to point that out. And when we look at it in totality, the average of our 4 months in this fiscal year in comparison to the average of our 12 months most recent year, we're running about a 14% cash performance increase over the prior year. So what does that mean to us? What that says to us is that we have opened up our communication. We are working our task activities, sharing reports with one another, and driving to execution. So we're seeing the benefits of the team working together, and kudos to that team again. We can go to the next slide unless there are questions on that particular slide. And so this slide really takes all of our inventory and says, okay, I'm here, I'm waiting on you. You finished providing the care, send me to an insurance provider or send me to someone to pay this bill. And there are a long list of things that we must do before we send this out. But we had some system issues in August. We have, since August, worked together each month. We have an owner and we have champions, and they continue to revise a plan each month. And so we see in August, we see in September, some improvements by about a day. I'm happy to also add as a note, our October performance is looking at around 6.5. So that is working for us. We're getting it to the quickness to this piece of it. Information is we have to turn it around as fast as possible. So every day we can shave off is a day or two or longer that we get the payment sooner. We can go to the next slide. There are no questions about that one. All right, denials management. A lot of work goes into this piece, but I want to point out a couple of things. If we look at the month of November of 2023, we hit a high point of about 784,000. If we trend over to the month of September, we're at 342. The difference between those two numbers for those 2 months, high and the low period, is about $400K per month. And so this is a result of the activities, and you can see that trend we're downward, right? We always want to see cash on the incline going up, but we also want to see denials management going down. Those two trends tell a story together. The work that occurs, I did bring up Faith's name, who was sitting in the back, pre-authorizations, making sure the patient, that we've notified their insurance provider before they come into the hospital so that we have a pathway for payment. Faith does a great job on that. Insurance provider, specific edits, Mark, Yasmin's not present. Those teams do a great job on that. It could be revenue reclasses. It could be charge discrepancies. But all of those questions, we have to provide the correct and accurate response to in a timely manner. In closing, I just will say our goal as a team is really to support the mission, vision, and values of NGH. We had a strategy general meeting, I think last Wednesday, and one of the things I walked away with is every day I wake up thinking about how can we make ourselves better as a team, particularly the revenue cycle and our contributions. But for me, it's making sure that our team members are accountable to Dr. Webb, to the board members, to our colleagues, to our patients, and to everyone else that we should be accountable to. And that's it for us. We'll continue our progress, move forward. Any questions?
These are pretty drastic changes from, July, August. What would you attribute to a significant decline, and, 10 to 6.7, and then you said even, I guess, we're trending lower for October on some of this. What do you attribute to the success?
Are you on the denials management slide?
Yeah, on denials management, sorry.
Yeah, the communication. So working the denials, this is every week. You should see the teams, and there are separate ad hoc meetings. I think I did mention Faith, but the work that we do from a utilization management standpoint, the work that we do with the insurance providers and understanding what is it they want us to submit and how, that work and that continuous communication, first of all, insurance groups change their request to us every day. So if we're not in constant communication with them, understanding what's needed and how it's needed and how we need to submit that, then we lose out. Now, it's not that we don't get paid, but it takes us longer to get paid. And the name of our game is to increase and improve net revenue and cash acceleration. Yeah. So this is about timing.
What would
And that's
be
what I
a
contribute.
reasonable goal for you if you would think kind of month over month to reduce, obviously, the average to?
The reasonable goal for us was probably, we're going to hit a floor somewhere in there. It's probably about 200,000, because what you see on the upside is us continuing to grow and increase our net revenue. So, right, you think about it, we're bringing in $200,000 more a month, $300,000 more a month, but yet our denials management dollars are still going. So probably around 200,000 is going to be our floor on average. And it will remain a challenge for us to keep it at that pace, because you got NPI changes. You have changes coming from the insurance providers every day. Yeah, so about 200,000 would probably be the floor for us.
And last question, sorry. So how is this comparative to, let's say, other hospitals and what their trends look like as well?
Other hospitals use a percentage.
Okay.
And so that percentage may be, typically is 6%. And so what we haven't did, we have it here. So we're right at 6% for September, 6.7.
Right.
Yeah, that's considered your best practice space.
Thank you.
You're welcome.
There are no more questions. We will move on to the next item on the agenda, which is contracts and capital expenditure requests. So the first item up is Epic's Anesthesia, and that is Bruce. Thank you.
Madam Chair, we need an approval of the financial statements. I'm sorry.
You're right. Sorry about that.
Move approval.
Thank you. And I will second. Any question? All in favor? Aye. Motion passes. Thank you. All right, back to you, Bruce. Sorry about that.
All right, this is our anesthesia provider here at the hospital for Veronica Elders, who was our chief nurse but recently had surgery. She's back part-time, but I'm going to cover this tonight just because I've been involved in it while she was out. This is a renewal of our existing anesthesia service contract. We have had some pretty dated rates of pay for the CRNAs and the physician that oversees the CRNAs here at the hospital. So for the first time, I think, similar to the conversation you may have heard last month from the ER group, for the first time, we lost one of our long-term CRNAs to a competing group across town. Our rates have always been lower, but the call coverage and the intensity of service here is a little bit lower than you would see at a Vanderbilt or an Ascension or an HCA. So we've had a really steady group of CRNAs, but eventually it got to a point where they lost somebody and they were about to lose a second, and they only have 6 CRNAs. and they were about $20,000 to $25,000 under market in Nashville. So they approached us basically to split the difference and raise the base pay for the CRNAs about $10,000 per person, and also a $25,000 stipend for the physician, and a $10,000 director for the other, director stipend for the other physician. So it's basically, we've not had any increase for the anesthesia providers, physician or CRNA, for probably 2 or 3 years, and we were just losing, they were losing staff to the market. So they came to us and we split the difference, and that's what we brought forward today, is an increase. It's about $117,000 annually. And like the emergency department contract, our anesthesia contract is basically a staffing contract. It says we provide this many CRNAs, this many physician, and an overhead cost, and then whatever they don't collect up to that $3.5 million, we write the check for the difference. And so in order to make this change, they have to change the base pay payment by that $117,000, and I think it's effective December 1st if the committee agrees. Administration supports it. We think it's reasonable, and we're sort of splitting the difference to try to keep their staff intact.
Bruce, I'm curious about the workforce here. How many? We got six full-time CRNAs that
Correct.
only work here.
I can't say they only work here, but they're full-time here, yes.
Okay, and one anesthesiologist.
Two.
And also full-time at
Yes,
General?
correct. And when I say full-time, Dr. Martin, you understand full-time, they may not physically be at the hospital 40 hours every week, but they're on call when they're not at the hospital. Obviously, we have obstetrics, so they have to be available all the time.
I mean, yeah.
Okay.
But they're not working somewhere else at the same time.
They're not working full-time somewhere else. I can't say that they don't
Okay.
ever go somewhere and take a shift here or there. I don't know. I'm not aware that they do.
And this page 38, it lists current salaries.
Yeah.
And
And I actually had another one that showed what the competitor, what our market looked like. They're pretty far behind.
yeah, it's a miracle that, you've kept them, because
It is. Well, you know what?
every hospital is struggling with this.
And that's the thing, because there was a large anesthesia provider in this marketplace that sort of dissolved recently. You probably know that, and they just went into the wind, and we thought we might get some, but instead, the other large entities in the area got much more aggressive, and they were even poaching hours for the first time. So
So I see the CRNA salaries.
Yeah.
Where's the MD salary?
it's not on here, but we're asking to increase it by 25. I think it's $440,000 a year.
Oh, actually, in the bottom, it says.
Oh, okay. I was
450.
basing it from memory.
Okay. Yeah, so it is in here. I see it now.
Yeah.
And is the annual retention bonus a one-time or?
No, it's part of their kind of stay pay, so it's built into the compensation on a go forward for the time being until we amend that contract.
So that'll stay as a separate designation?
Yes.
I'm just curious, why isn't it just put into their salaries? Why is it a separate item? Retention bonuses.
You know what? I'm not their employer or whatever, so however North Star Anesthesia or
how they
Epic
present
chooses
it to
to
you.
do it,
Okay.
I don't know if it's handcuffs and that has issues if they departed, but I can't speak to that. They're not our employees. That's part of their cost of doing business. We don't.
Do they sign a contract? Are you aware of any of the contractual arrangements, again, with the staffing agency that we're using? I mean, I'm just wondering, it does look like they have long tenure, but just curious about is it a 3-year contract? Is it, what their,
I mean, what the individual CRNAs or physicians' contracts are, I don't.
just curious.
I don't know that. I mean, under any circumstance, Epics is bound to provide the 6 CRNAs, even if they lost all 6 of them tomorrow, but they'd be paying $250 an hour for PRN coverage, and they would quickly be running in here to either terminate the contract or figure something out. But we don't control that, Chair.
So we're not actually paying directly the salaries we see here?
No, this is just their justification
this shows
for
their
why the
justification
request
for
was
why
made.
Yeah, I got it.
Okay.
Okay. All right. No more questions. Move approved.
Thank you.
yeah. I will second the approval. If there's no other conversation and question, then motion, all in favor?
Aye.
Motion passes.
Thank you.
Okay, next contract is Edwards Pathologist Service and Mark Brown. Oh,
Good evening. I'm proposing today a contract for pathology services with Dr. Edwards. We have one full-time pathologist that works in the laboratory currently, and so we're seeking to add a second pathologist to that group.
So is this the same thing like we have a contract to pay this pathology group, and then they pay the pathologist
Yes.
salaries?
Yes, this would be directly to that pathologist. It's a little bit different setup than we had in imaging, if that's your question, Dr. Martin.
Or different from anesthesia?
Right.
Yeah, okay.
This is just one person, though, is what I
Correct.
understand. Okay. The language in the contract speaks, I think, speaks to the group and then also the individual.
Right.
But I'm guessing it's just one person.
Yes, ma'am.
The next question I have is with regard to, I guess, the demand and revenue to offset the $441,000. So tell us a little bit about the current demand and why we're hiring a second, and then also are we able to cover the cost of this new person and what the expectation is?
Okay, so we are expecting the revenue to go up by our off-sites, moving those once we go to Cerner back in-house. Right now, we send that. Those bills are going out to Quest, and so those will come in-house. The other reason why we're looking to add a second pathologist is because one of the pathologists is a very tenured pathologist, and so if he goes away, and then we have another pathologist that works extremely part-time. And so we won't have enough coverage if something was to happen with those two providers.
So were we sending things out to Quest because they're specialized tests, or because we didn't have enough staff to cover it?
Those are because of technology, Dr. Martin. We can't connect the EHRs in to pull in. So once we get Cerner, then we can take on those extra tests that are outside of the hospital. Currently, because of the way we have the Paragon and the ECW set up, the results doesn't cross over.
So we've got the technology to do the tests already.
Correct. But we can't bill for those tests that we are sending out to Quest because of technological reasons. It doesn't cross over. And so we end up having to go back and put them into the computer system manually. And so it's just easier for us to get Quest to do those tests and send those out from our outpatient clinics.
So currently we're giving up the revenue of those tests.
Correct.
And we'll get them back
We'll
in-house?
get those back, yes, sir.
Okay. And is that projected to come up with the, close to what it costs to have a second pathologist?
Yes, it'll cover some of the costs. I'm not going to stand here and share with you that it's going to cover the total cost, no. But I think if we don't have, it's the same thing with when we hired on Dr. James. If you don't have the coverage right now, one of the pathologists is up in age, like really up in age, and their scope is very limited to one section of the lab. The other pathologist that works really part-time, they're able to cover some of the call coverage and some of the coverage in the lab, but with their availability, I'm not sure if something happens that we'll be able to keep the lab up and going.
Speaking of employment contracts, is there an employment contract that I'm sure there is that we have with this full-time tenured limited scope employee? And if so, when does that contract come to completion as well as our part-time?
So that is a part of the PSA agreement that we have with Meharry Medical College. That pathologist is a Meharry employee.
And the same with the part-time?
Part-time, yes, ma'am.
Has there been any indication that those two individuals are giving any kind of time frame to retire, et cetera?
No.
Not at this point?
No.
So does Meharry have other pathologists that are not working here?
We have one other pathologist that's not working here that is at Meharry, but it does not work in the lab.
Okay.
I think what you're hearing us say is we're just trying to understand and
I
make sure we
understand,
get
Madam
the
Chair.
cost.
Trust me, I'm not
just
taking
understand.
offense. I'm
Yeah.
just trying to answer the question the best I can.
Yeah, we were just trying to say, is the Quest piece as well as the extra generation, whether it be demand, et cetera, going to cover $441,648? And is there another option to do that? Or I understand for continuity and different options, it sounds like that is also a reason. But I guess that's right. Isn't that fair? We're just trying to justify the cost here,
right.
and I think that's what you're hearing from us.
Right.
Well, and the other question is, if we have pathologies in the PSA with Meharry, are they unable to hire another pathologist, or how does that work? I know that there are some specialties where we're able to hire on people because Meharry is unable to provide them. Here we have somebody from Meharry. Are we obligated to ask Meharry to provide another pathologist since this is in the PSA? How does that work?
Well, that's where we got Dr. James from. Dr. James was leaving the organization to take a position somewhere else, which would have left us without a pathologist.
Right. Okay.
And so that's how we ended up with Dr. James. Before he left, he approached me and shared with me that he was leaving to take a job somewhere else. And then I asked him, is there anything that we could do to keep him on staff here? And that's how we ended up getting Dr. James.
Is Dr. James the senior pathologist or the part-time?
No, Dr. James is our pathologist who is I would say he's a mid-careerist pathologist. He's rather younger pathologist.
But there is a Meharry pathologist that works here?
Yes, sir.
And that is?
Dr. Ballard. Dr. Ballard is, I'm just going to say it now that you're forcing me out, Dr. Martin. I'm going to say Dr. Ballard is a little over 80 years old.
Okay. I got the picture now.
Okay. You pulled it out of me.
Let me make a comment to the pathology service. That is more than just a lab service. That carries a high risk, and all you need is for one error or mishap in that area, and you'll be paying for 10 pathologists for a while.
Yeah.
So it's not something you want to really try and cut costs and skimp and get someone that's going to be there part-time, and you've got to have committed people in that area. And Dr. James
Yes.
is energetic. He's well-trained. He's very committed. He's bringing on a second. You cannot have one pathologist running a full lab, so you've got to have an additional resource there.
Okay, yeah, I'm not questioning it, I'm just trying to understand
Well,
the players here.
I'm trying to help you to understand.
Thank you. You have. You have. And you also, if you've got an older person as your primary and suddenly that person's not here, you're in a heck of a mess. Dude.
So
No further questions.
you're saying that the current person that we talked about, there's the new person, there's still going to be the halftime person. Is that correct? So 2.5 people?
So the new person will make 2 pathologists for
Right.
NGH. Then you have a part-time pathologist that works with Meharry, and then Dr. Ballard works for Meharry. And he's still on the platform teaching as well.
Okay.
So a lot of his time is geared towards teaching. And then he does cover the pathology part of the lab.
Got it. Okay. All right. There's no more discussion. Then I will entertain a motion to approve the Edwards Pathologist Services.
So moved.
Second, seeing no discussion, all in favor?
Aye.
Aye. Motion passes. Thank you for your time and answering the questions. All right, that is the last item on the agenda, so we will go ahead and adjourn for the Finance Committee meeting. Thank you.